Welcome to part 2 of our presentation on Chapter 13, Pregnancy and Childbirth. As with part 1, I wanted to go outside of the text and present you with some information that I think will be useful to you in your future lives if you decide to become parents, or if people that you know and love decide to become parents. So a lot of this information comes from the Department of Health and Human Services, the womenshealth.gov website, which has a wealth of really just practical information for people to seek out if you want information on pregnancy and childbirth. So in talking about preparation for childbirth, a lot of people in the United States report that what they have learned about childbirth primarily comes from the media through sitcoms and movies and other kinds of media presentations. So it's important that people prepare for childbirth by getting accurate and timely information. There are lots of classes. Many doctors will recommend to their patients that they take a childbirth preparation course. There are a number of different methods. Probably the two most common are the Lamaze technique, which is described at length in your text, and the Bradley method. Most of the time, these classes are offered within a hospital context. Some are privately offered, however. Some are offered directly through an OBGYN service. Most women attend classes with a person who will support them during labor. Sometimes it's their partner, sometimes it's a good friend or a sister or mother, whoever that person has designated as someone who they want to be present at the birth of their child. There are also breastfeeding classes. Again, some of these take place in hospitals, and sometimes they're wrapped in with just a general pre-childbirth class where you get information on Lamaze techniques, basic information about the childbirth process, and then basic information about the postnatal, the immediate postnatal period, plus breastfeeding. So a lot of these classes, and this is the kind of class that I attended, kind of wrap the whole thing together, where you have information about the basics of childbirth, and then breathing techniques, relaxation techniques, and coaching techniques, and then how to care for your newborn and breastfeeding. There are some standalone breastfeeding courses, however, which can be extremely useful because unlike the common stereotype, breastfeeding doesn't just happen. There's often a significant learning curve for teaching women how to breastfeed. There are also parenting classes, and these are not just for people who've proven themselves to be inadequate parents. Many first-time parents have never taken care of a baby and don't have a good kind of background to prepare them for how to take care of their newborn at home. Many hospitals, other kinds of community centers, and often churches and temples offer these basic baby care classes. Sometimes city and county government have classes that are designed to help particularly families that are on government assistance with basic parenting skills. And it's not because those families are particularly negligent, it's because they are the ones who have access to the funding that supports these kinds of classes. So what these classes cover are basic things like diapering, bathing, feeding, and also basic skills that are related to sleeping, such as sleeping position and the context of sleeping, like should babies be swaddled, should they be on their backs, should they be on their stomachs, and so on. Now, most hospitals you are required at the time you check out to go through some basic skills tutoring. I know that with my first child, before I left the hospital, I believe it was on day 2, they kind of corralled all the new moms into a room, and we were given a basic presentation on the whole diapering, feeding, bathing, sleeping kind of thing. Wrapped into that was some self-care stuff about how your body recovers from the birth process. Now we need to go over, and this is kind of the thing that if you were in a pre-delivery series of courses, a teacher would go over these things with you. I'm presenting the information that's contained on womenshealth.gov. Your text also covers the basic 3-part process of pregnancy. The first trimester is described as weeks 1 through 12. And during this trimester, and I'm presenting this exactly the way it's presented on womenshealth.gov, it's designed for a person who's newly pregnant or is planning to get pregnant could go to this site and say, what should I expect week to week in my experiences? And there are other websites out there, some of them commercial, some of them not commercial, that do the tracking like down to the week. This is going to just be broken up into trimesters. So what women report when they become pregnant is that their bodies start to change very quickly. Hormonal changes affect virtually the entire body, top to bottom. And from personal experience, I can say that that's absolutely the case. One early sign of pregnancy is that you miss a period. Other changes, and people are very different. Women will tell you that they experience, even from one pregnancy to the next, very different physical and emotional experiences. Many women report being more tired. Many women report breast changes, stomach changes, morning sickness isn't just a morning thing. I don't know who thought that up. But generally, when people have the nausea associated with the first trimester of pregnancy, it's not really just morning. It may be more intense in the morning because it tends to be worse when the stomach is completely empty. But most women report it's sort of unpredictable and may be triggered by certain smells. Some women report cravings or a change in how foods taste. They may also report different sensitivities to smell. For example, I like the smell of books. I know this sounds ridiculously stupid, but while I was pregnant, both times the smell of paper was nauseating. So women report really idiosyncratic taste changes, really idiosyncratic smell changes, and things that would either trigger nausea or hunger. Many women report changes in their moods, although it's kind of unpredictable in what way. For the stereotype is that women get really moody, that they're weepy one second and they're joyful the next. That stereotype isn't particularly reliable. Some women report if they have a history of depression or anxiety that those experiences intensify, particularly if they've had to go off of a stable course of medication. Other women report feeling joyful and happy, although having occasional times of feeling moody or sad. It's unclear whether these mood changes are connected to the actual biological fact of pregnancy or if they're more likely due to changes in lifestyle or to cultural expectations. Many women report changes in their bowel habits. A lot of that is due to hormonal changes. As the weeks 1 through 12 progress, the need to urinate more frequently increases. Some women do report, headache, heartburn, weight gain or loss, depending on the degree to which their eating changes during the first trimester. In the second trimester, this is 13 to 28 weeks, most women report, although there are tremendous individual differences, most women report the second trimester is somewhat easier than the first because there's often a decrease or at least an increase in the ability to manage the symptoms of nausea that might happen. Nausea and fatigue tend to level off or even decrease. But there are also some bigger changes to your body during the second trimester. Um, Obviously, the baby bump happens, as celebrities are so fond of documenting online, and the rest of humanity has started to document on Instagram, um, the changes of the ever expanding abdomen across the second trimester. But before the second trimester ends, so sometime before week 28, the movements of the baby will become evident. You can feel it. If you're the woman, you can feel it inside. As first off, it may feel like a fluttering. As the second trimester progresses after that first quickening, it will be more like being punched and kicked. But that's more for the third trimester. So early signs of movement, it feels kind of fluttery. That first time when you sense that movement is often referred to as a quickening. For the not mother, whoever other people will be able to place their hand or the side of their face to the belly and can feel those movements as you get closer to the end of that second trimester. Some other changes that women report during the second trimester of pregnancy, they may report being a bit more achy. As you are gestating a new baby inside of you, it stresses the body. There are stresses on especially the hips and the lower back, the knees, the ankles, particularly for women who were already statistically overweight when they became pregnant. They may experience more joint difficulties as they move through their pregnancy. For anyone, regardless of their baseline BMI, women do tend to report stress on particularly their lower joints. You might notice stretch marks. There is a tendency for darkening of the skin around the nipples, and a line running from the navel to the beginning of the pubic hair. Some women also report darker skin appearing over their cheeks and forehead. This is a hormonal effect. For some women, that darkening of the skin in patches, and it's mostly subtle, will remain after pregnancy for quite some time. Some women report some carpal tunnel-like syndrome experiences in their hands. And in part, that's probably due to just some systemic swelling and inflammation. Some women also report swelling of the ankles, fingers, and face during this period of time. The third trimester is 29 weeks to 40 weeks. At this point, and you've seen pregnant people, breathing becomes difficult. You have a baby sitting on your bladder. You have a baby pushing up against your diaphragm. It can start to get hard to find a comfortable position. It can be easy to become breathless, to become winded, especially if the baby that you're carrying is bigger. As that baby gets closer and closer to the 40-week mark, there's just not a lot of room left. So as the pregnant mom, your organs are getting to the point where they're competing with space for your growing baby. So other changes that women report, shortness of breath, heartburn because the baby is pushing on everything from below. It can cause reflux to occur, where acid is pushed out of the stomach and into the throat. Many more women report the swelling of ankles, fingers, and face during the third trimester than the second. Some women develop hemorrhoids. Most women start to experience increasing breast tenderness as they move closer and closer to week 40. For some women, their belly buttons pop out. And someone joked with me that, oh, that's a sign on a turkey that the turkey's done. And I thought that was the stupidest thing I'd ever heard. But it's kind of right. Many women report that they start to have more difficulty sleeping. Part of that is because it gets harder to find a comfortable place to sleep, to a comfortable position in which to sleep. But also because babies, they don't have any kind of respect for the nighttime sleep cycle, they may be moving around, they may be poking and kicking and bumping around, and they do so on and off around the clock. So for many women, they report having trouble sleeping. The baby will at some point start to drop, moving lower and lower in the abdomen and in preparation for birth, and also turning. So in the normal sequence of events, a baby will reorient with their head down in preparation for birth. And physicians, OBGYNs, nurse midwives, they'll check for this to see whether or not the baby has dropped and turned. Many women, and I had this experience, report throughout the third trimester these minor contractions. They're called Braxton Hicks contractions, which they feel like mildly uncomfortable, but nothing like what you would experience in actual labor contractions. Sometimes they feel a bit like having the kinds of cramping that you would experience during menstruation, but not quite the same. So many women find it confusing. They may have these Braxton Hicks contractions on and off days for days and days on end. From my experience with both of my pregnancies, I had these minor contractions throughout the majority of my third trimesters. So it was kind of easy to just start to ignore them. They are sometimes confusable with real labor. The difference would be the length and duration and predictable occurrence of those contractions. The closer you get to your due date, and again, your practitioner, either your OB, your GYN, your nurse midwife, or your midwife will check this. Your cervix is going to start to thin out and become softer, because that cervix has been designed for the entirety of the pregnancy to keep the door closed, if you forgive that description. Now it needs to thin out and get ready to open up so that the baby can be delivered. So your healthcare professional is going to track that and use it as a way of predicting generally how close you are to delivery. Now, what are some signs of labor? The womenshealth.gov website recommends, and these will be the same kinds of recommendations you get from your healthcare provider. It's recommended that you call your doctor or midwife if you have any of the following. You start to have contractions that become stronger and at an increasing level of strength and are regular, and the intervals between the contractions start to get shorter over time. In pre-childbirth classes, you'll be taught how to monitor and time contractions. And as I said, it can be confusing. You've been pregnant a long time and you're used to having these minor Braxton Hicks kinds of contractions. It can sometimes be confusing to decide, are the feelings that I'm having now qualitatively different? Some women report that the first sign of labor for them was a decidedly acute lower back pain and cramping. Some women report that this feels a lot like the severe kind of menstrual cramps that they would have that kind of wrap around to the back. The distinction would be that this is cramping and lower back pain that doesn't go away. Now, I only experienced this with my first pregnancy because my second pregnancy was induced. But in my first pregnancy, I did experience some fairly significant lower back pain and cramping that didn't go away, that came on in advance of when my water broke. So that's the next thing. A clear sign of labor is when the water breaks. It can come out in a gush, or it can come out in little trickles. I experienced this with my first pregnancy, and that's when I said to my husband, I think it's time, because my water broke during the middle of the night. Some women report having a bloody brownish or red mucus discharge. There's a plug of mucus that is at the entrance to the cervix, blocking it to keep, outside substances from coming in. At the point where labor is going to begin, that plug may be discharged. So some women may report that they'll see that. Sometimes this happens in advance of the water breaking. Sometimes it's simultaneous. What this usually means, if the mucus plug has been discharged, that usually means that the cervix is dilated such that it just doesn't hold on to the plug anymore. And that means that labor could be starting. Women vary tremendously in terms of how quickly labor is going to get underway after that occurs. And women report that from one pregnancy to another, the timing is not the same. So it may be right away, or it may be several hours. And some women will start and then may stall, depending. So tremendous variability there. Now the first stage of labor begins with the onset of labor, and sometimes marking that is difficult because everyone is a little bit different, but it starts with the onset of reliably increasing in intensity contractions and the changes in the cervix. Labor will be kind of marked by changes in that cervix. Over the time of labor, what you're looking for is the cervix to become fully effaced and open. Usually this first stage is the longest stage of labor because there are changes in that cervical opening and the preparation of the body to allow a fairly large little human to be passed through the vaginal opening. Nearing the end of that first stage of labor, there will be a marked transition with contractions becoming longer and stronger and more tightly clustered. The most difficult, according to what women report, as long as you're talking an unmedicated labor, most women report that the most difficult part of their experience in terms of pain and discomfort is the transition stage, because that's the moment when the contractions become much more intense, longer and more painful for women. Now that said, women report very big differences in terms of their experiences of this stage. In the second stage of labor, what's happening here is that the woman is told to push, and the first stage of labor, you're kind of allowing the contractions to do their job, to efface and stretch the cervix, and for the baby to move into final position and readiness. The second stage involves actually pushing the baby out. It usually, under normal circumstances, is going to last between 20 minutes or so and a couple of hours, although there are tremendous variabilities there, depending on the size of the baby, the physical condition of mom, and a variety of other factors. When the top of the baby's head appears, the doctor will tell you to push and to deliver your baby. Under some circumstances, the doctor may decide to make a small cut in the vaginal opening to enlarge it. That's called an episiotomy. It's a somewhat controversial procedure. Doctors have sometimes argued that making the episiotomy cut will decrease the likelihood of the vaginal opening tearing and is easier to therefore stitch up than multiple discrete tears. It's controversial because some natural birth advocates argue that in fact creating the episiotomy opening causes more damage, more discomfort, slower healing than naturally occurring tears, even if those tears have to be repaired. So that's something to discuss with your care provider. Luckily, most women in childbirth don't need an episiotomy. There used to be a time when episiotomies were done almost as a normal course of of childbirth and delivery, but their incidence has decreased. There are times when, especially if you have a large birth weight baby, or a woman whose just anatomy is smaller, that forceps may need to be used to help guide the baby through the birth canal. In the third stage of labor, and you're thinking, why is there a third stage? The baby's out. Well, there's a remaining kind of events that have to occur. The third stage involves delivering the placenta, sometimes called the afterbirth. It's the shortest stage. It's usually about 30 minutes long. Contractions for this stage of labor usually begin about 30 minutes after the baby's delivered, and then the placenta is delivered. This has to happen because you have to deliver out the remaining tissues that were inside to support the growth and development of the baby. If those tissues remain inside, or some portion of them, it can cause very dangerous infections for people. Many women report having, during this period of labor, chills and shaking. It's just a natural part of the delivery process. Labor is declared over once the placenta is out. At that point, your doctor, if you've had an episiotomy or any tears, those would be repaired. And in the meantime, your baby's being examined, and any kind of needs that the baby has are going to be taken care of. And then you'll be reunited with your little one. Now, there are lots of options for pain control. In some cases, these medical pain control options will not be necessary, and there are lots of decisions that you need to make, and there's a conversation, actually a series of conversations that you need to have with your healthcare professional about whether or not you want to pursue medical pain control. Many women will go into this process saying, I don't want to expose my baby to any kind of medical pain control. I want to go natural. And doctors will often say, that's great, I support your decision. Let's talk about what might happen, though, so that you know what your options are. If you need, over the course of, say, your labor is progressing very slowly, or we need to induce delivery, you need to know what your options are so that you can make mindful decisions should the time come. Some of the most common medical pain control approaches, there are narcotics or opioids that can make pain more manageable. They have some pros and cons. They don't typically get rid of all the pain. They tend to be short acting, and they can make people sleepy. They can also, in some cases, slow the process of delivery. There are epidurals and spinal blocks, where a catheter is placed into the spinal cord area, into a space just below the spinal cord, and then small doses of sensation blocking medicine are introduced. These are usually given only, the epidurals may be introduced at multiple points. Spinal blocks are typically done only once during labor. These are conducted by an anesthesiologist who inserts the catheter with a needle into the spine. From personal experience, it's not a comfortable thing to go through. If you've ever had spinal injections, you kind of have a preview of what that might feel like. With an epidural, pain relief starts fairly quickly. In my experience of it, I basically couldn't feel anything from the waist down, other than maybe pressure, but definitely no pain. The degree of numbness can be adjusted during the course of labor and delivery. With a spinal block, you have immediate pain relief, but it's not going to last as long. So for many women, they opt for an epidural that's going to have the duration to last through the majority of their labor and delivery. There are some disadvantages. I'm not going to go through all of these, but after the medication wears off, you may still have some difficulty walking and moving around. I remember when I had my epidural and I'd already delivered the baby. About an hour later, they wanted to escort me to the bathroom, and it felt like I had sandbags on my feet. Um, epidurals can cause your blood pressure to crash a bit, but that's a rare occurrence. It can also slow the baby's heart rate in some cases. So those things have to be addressed during the course of labor and delivery. Epidurals can also extend labor in some cases. If you're given an epidural late in labor, and too much medicine is used, it may make it difficult for you to push the baby out if you don't have enough muscle control. Another option is called a pudendal block, and in this case, you have an injection of numbing medication into the vagina and near the pudendal nerve. And this is typically only used during late-stage labor, right before the baby's head comes out, and it's designed to block some of the pain that's directly associated with pushing the baby through the vaginal opening. Now, some of you were asking questions on perusal about cesarean sections. And again, most of what we know about cesarean sections comes from media exposure. Unless you have someone in your life who's had a C-section or can tell you about it, or if you've had one yourself, you really haven't given it a lot of consideration. There are some concrete good reasons for having a C-section. In some cases of multiple births, a C-section is warranted because those deliveries are already considered to be high risk, and it can be a way of ensuring more control over the delivery process and the greater likelihood of delivering all of the babies successfully. For some women who have pre-existing health problems, for example, HIV infections, herpes infections, heart disease, blood pressure problems, if those are the case, then a C-section may be decided as the best way to go. Now you might be thinking, why HIV and herpes? HIV and herpes can be transmitted to the baby during the process of delivery unless a C-section is done. And research has shown, especially for HIV infection, that the rate of transmission to the baby can be greatly reduced if a C-section is done. So if mom is HIV positive, it may be seen as highly beneficial to deliver the baby by C-section. If mothers have dangerously high blood pressure, and for some women they already had high blood pressure before they got pregnant, others develop high blood pressure during pregnancy. Dangerously high blood pressure is dangerous to the life of the mother. It can be associated with blood clots, cerebral hemorrhages, and a variety of other problems. So it's often seen as a life-preserving decision to have a cesarean section when mom has very high blood pressure. Some women, the shape of their pelvis and the size of the baby make a natural delivery highly unlikely, or it's determined that it would be very difficult. So just the nature and the shape of the pelvis may predetermine a cesarean. If women have a documented history of placenta problems, so the placenta separating or placenta previa, that if that's a known risk factor, a C-section may be warranted. If it's determined on ultrasound that the umbilical cord is wrapped, say, around the baby's neck, and their efforts have been taken, but they have not been able to reposition the baby such that that umbilical cord can be moved, then a C-section may be required. If the position of the baby can't be corrected, if the baby is feet down, as in a breech position, or is kind of lodged sideways, and no manipulation has successfully gotten the baby to turn into a more appropriate position, a C-section may be warranted. There are cases where During the process of delivery, the baby shows distress, like their heart rate crashes, then it may be determined that unless delivery happens right now, that baby would be in serious danger. In some cases, what they're trying to avoid is a situation of anoxia or even fetal death. It used to be recommended, if you've had one C-section, it was almost just assumed you had to have all of your other children via C-section. That's not assumed as much now. In some cases, it's still it's determined that if you've had a C-section in the past, it's the safest option to go with a C-section in the future. But as I said, the norms have shifted. It's been found that more and more women are able to have natural deliveries after they've had a C-section for whatever reason. Now, some of you asked, I think at least one of you asked a question about women coming into their healthcare providers and saying, I want a C-section no matter what. And you were asking, the right questions. Do people do that? Should they do that? Is that medically appropriate? On womenshealth.gov, it was reported that a growing number of women are asking their doctors for C-sections without a medical reason for having one. Now remember, a C-section is a surgical procedure. You're having your abdomen opened up, even though the size of the incision in the modern era is much smaller than it used to be. You're still having a surgical procedure that is not without risk and not without consequence. So why are some women asking for C-sections when there's no medical justification for doing so? Some women say that they're just fearful of the pain of childbirth and they would like to avoid it altogether. Others like to be able to schedule. They like to decide when and how they're going to deliver the baby and have it controlled. Others believe that the tearing and kind of what in some surveys women describe as the trauma of childbirth will change their anatomy to such an extent that it will influence their sexuality and their sexual experience. So many are asking for that. The question, though, becomes, is it appropriate, is it safe, is it ethical for doctors to allow women to opt for a C-section? And, obviously, people who have a lot of resources, they can probably doctor shop until they can find someone who gives them what they want. But if you look at it from an ethical perspective, there are pros and cons, and the answer is unclear. For many obstetricians and gynecologists, they feel they have to, just as a matter of ethics, educate women and their partners out of elective C-sections, because from their point of view, the risks do not outweigh the benefits, or the risks outweigh the benefits of doing so. So the risks of having a C-section, because it is a surgical procedure, outweigh the supposed benefits of avoiding pain and suffering and the physical changes to the vaginal anatomy. Still others, though, other obstetricians, gynecologists believe that, women have a right to choose. And if they want to have a C-section and they understand the risks and benefits, it's their right to make that decision. In terms of actual medical outcomes, that's still an open question, and research needs to be done to answer some of those questions. Now, one issue after delivery that really needs to be taken into serious consideration is the possibility of postpartum depression. What people experience, what women report, is, and these are kind of the warning signs. If you see in yourself after delivery, or if you see in a new mother that's in your life, any of the following, it really demands a follow-up with a physician. Feeling restless and irritable, feeling sad, depressed, and crying a lot, depleted energy, lots of headaches, chest pains, heart palpitations, and those are associated with panic or near panic episodes. Disturbed sleep. Now you might be saying, you have a newborn in the house, you don't get to sleep. Well, not being able to fall asleep or stay asleep, even when the baby is not an issue, is a disturbance of sleep. Um, not being able to eat and suffering weight loss, so a disturbance of eating that way, or the reverse, overeating and experiencing weight gain, cognitive changes like changes in focus, memory, and decision making. Um, in some cases, being obsessively worried about the baby's well-being, or not having an interest or not feeling connected to the baby, overwhelming feelings of worthlessness and guilt, not having an interest in things that used to be pleasurable or enjoyable, and thoughts of harming yourself or your baby. All of those are things that you should be concerned about. Um, if you've given birth and you are experiencing those things, you should be talking to your healthcare provider immediately. Now, unfortunately, many women feel like they don't have a right to feel bad. They don't understand what's wrong with them. They must be failing at being moms. So, unfortunately, many women don't report feeling depressed and therefore don't get the help that they need in order to resolve their postpartum depression. Now, another issue that we need to talk about, and this is both a national and international issue, is maternal mortality. And the data that I'm going to show you here comes from the World Health Organization, which tracks maternal mortality rates around the globe. The WHO reports that, and this is based on 2017 data, every day approximately 810 women died from preventable causes that were connected to pregnancy and childbirth. Between 2000 and 2017, the ratio, the maternal mortality ratio, so the number of deaths per 100,000 live births, has been dropping. And if we're looking at that from a worldwide standpoint, but also from a U.S. standpoint, that's a good story to tell. Most industrialized countries have reported over the last 20 years steadily decreasing rates of maternal mortality. And what's driving that is increases in access to reliable health care, prenatal care, labor and delivery care, and postnatal care. If you're looking at the United States, the majority of maternal deaths, and this would be internationally as well, the majority of maternal deaths are among people who are low and lower middle income. If you're looking at it from a country standpoint, the overwhelming 94% of maternal deaths are going to show up in low income countries and lower middle income countries. Within country, the poorest people have the highest rates of maternal death, and that's true in the United States as well. What's also true is that young adolescents, kids between the ages of 10 and 14, face the highest risks of complications and death as a result of pregnancy. So these very young people, young adolescents, when they become pregnant, and pregnancies do occur between the ages of 10 and 14, when your body isn't fully developed, it's not fully physically ready for the rigors of pregnancy or childbirth. So these young people experience higher complications and are significantly more likely to die during childbirth or directly afterwards. What's been determined, regardless of what country you're in, when women have access to healthcare professionals who are trained both during their pregnancies and during and after childbirth, that maternal mortality rates go down and newborn mortality rates go down. When women do not have access to high quality or even moderate quality health care before, during, and after childbirth, the rates of maternal mortality and newborn fatality go up. The WHO has argued for a long time the majority of maternal deaths are preventable, meaning that they're caused by factors that could, under better circumstances of more effective health care, they could have been avoided. What this suggests, and this is the argument that the WHO makes, is that all women should be given access to high quality care during pregnancy, during labor and delivery, and after childbirth. And that would increase the likelihood of women remaining healthy and, in fact, remaining alive after their pregnancies. Some of the major causes, when births are attended by someone with training, someone who has professional training, whether it's an OBGYN, a certified nurse midwife, or a certified midwife, people with skilled training, you see lower likelihood of severe bleeding after birth that can cause death within hours. Essentially, if you have a major bleed, women can bleed out within hours after birth if not attended by a professional who can find the source of the bleeding, stop the bleeding, and surgically repair it if necessary. Post-birth infections can be prevented if women have adequate supervision, if they're trained, if they're talked to by skilled professionals about hygiene, and if early signs of infection are noted, such as changes in vaginal secretions or the incidence of fever, and then medications are delivered in a timely way. And also preeclampsia, which is high blood pressure, dangerously high blood pressure that wouldn't be detected unless you had a healthcare professional who was routinely taking blood pressure readings. So in cultures and countries, or in parts of countries where people are more likely to have either an unattended birth or a birth attended by an unskilled person, such as a family member or a local individual who's an untrained midwife, these factors, and these are the three primary reasons why women would die postnatally or during birth and delivery, is severe bleeding, infection, and preeclampsia related problems. So countries that want to reduce their maternal mortality rates, there are some key things. You increase the rate at which women have access to a skilled professional or a skilled and trained paraprofessional. Also, you need to reduce the number of unwanted pregnancies. So in some cases, research has shown that unattended pregnancy is sometimes precipitated by having the pregnancy be unwanted. And maybe it's a very young mother who didn't intend to get pregnant, maybe wasn't even aware of their pregnancy until very late, and they attempt to hide it, or their family wants it hidden. That may increase the likelihood of an unattended birth, and therefore some negative outcomes. With unwanted pregnancies, that you have an increased likelihood of seeing behaviors during pregnancy that increase some of the possibility of negative consequences, such as not being able to pursue adequate health promoting prenatal care. So one of the ways of avoiding maternal death is to have high quality prenatal care and then supervised birth, but also preventing unwanted pregnancies in the first place. Finally, the WHO recommends that for all women, including adolescents, people who are very young, that they need access to, and that means unfettered access, like not having to go through a judge or even a parent. They need access to contraception and abortion services. So the WHO takes a stand here, saying that all women, regardless of where they are, if you want to reduce maternal death rates, they need to have access to safe, effective contraception and abortion services. So, you know, I wanted to be transparent about that. The World Health Organization takes a particular stance, and their their value structure says that um, we need to reduce maternal mortality. We need to ensure the health and safety of women. So this is what their recommendation is. Now, some questions that are asked by the World Health Organization researchers that are important for you as students to kind of wrap your head around. You might ask yourself, what are the major reasons why women don't get the care they need in the countries around the world? Well, the number one reason is that they're poor. So if women are in poverty, and this is the case in the United States, it's the case everywhere on the globe, the poorer women are, the less likely they are to have access to quality health care, period, but also quality prenatal care, quality care for labor and delivery, and quality postnatal care. Um, also, and this is kind of wrapped up in the poverty issue, many women don't get the care that they need because they're too far away from facilities to access them. I was listening to a radio story this morning about COVID-19, and they were talking about how in some parts of the country, particularly in rural areas, the crisis with COVID may be exacerbated by how far people have to travel to get to healthcare facilities. And when they get to those healthcare facilities, they're not well prepared to deal with the events that are taking place. Well, the same thing kind of goes for pregnancy, labor, and delivery. Maternal mortality in the United States, for example, is far higher in rural areas and in areas where you have high concentrations of people who are poor, rural, and people of color. One factor that plays into maternal mortality is women not having access to appropriate information. And that can include, not having good education as children and adolescents to understand contraception, to understand pregnancy, to understand labor and delivery. There is also the factor of inadequate services or low quality services. As I was saying before, especially in poor communities where poverty rates are high, where there's relatively high distance to get to a healthcare facility, those facilities often lack sophisticated technologies. They may not have the highest trained staff or the level of staffing that is necessary to ensure that people have adequate access. Then there's also a variety of cultural beliefs and practices that can increase the possibility of maternal mortality. There are cultures in which their beliefs and practices forbid medical intervention with a variety of things, and that can increase the rate of maternal mortality. Now we're going to finish with yes, pregnancy happens, and you might be thinking, what happens to your sex life after pregnancy? There is sex after pregnancy. I've been told it happens. Many healthcare professionals recommend that you wait 4 to 6 weeks before having sex after giving birth. This gives your body time to recover, time to rebuild some resources that have been depleted over the course of pregnancy. If you've had an episiotomy or any tearing, it gives time for that to heal. You will also you'll experience the equivalent to your longest period after giving birth. So there's a considerable amount of bleeding, not unlike but not completely the same as menstrual bleeding after pregnancy. So most physicians are going to recommend 4 to 6 weeks after childbirth. Now, in research, some women report problems, although it's not the majority. The majority of women report, high levels of sexual satisfaction returning after their postpartum period has concluded. What some women may report, they may report pain during intercourse, which can usually be resolved with the use of lubricants and adequate pre-sexual stimulation. Some women report, in addition to feeling some depression, their sex drive may have decreased. This kind of depends on the method of delivery. If someone had a difficult vaginal delivery, they may experience more discomfort. Or in some cases, if they've had a C-section, they may have some lingering abdominal pain and discomfort. Some women report complications with breastfeeding. For instance, if they become aroused, they may have leaking, or their breast may simply be hypersensitive or even sore as a result of breastfeeding, and that may interfere with their sexual satisfaction. And finally, some women report mood changes. Now, as I said, the majority of women report returning to their pre-pregnancy level of sexual satisfaction fairly rapidly after the postpartum period is over. If they don't, they are encouraged to talk to their healthcare professionals and find out what's going on and what can be done to correct it. So that concludes my coverage of Chapter 13. I'll see you next time.